The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, everyone. We are here for the next episode of TMD Demystified. My name is Tony Urbanek. Today's topic that I chose is a very, as most of my topics I believe are, very important. Today we're going to talk about, are my headaches migraines or TMD? Are these bad headaches that I've been having for 30 years that come and go, that make me sick to my stomach, that give me aura, visual disturbances, plenty of pain, sometimes puts me to bed, I can't move? Is it actually migraine headache or TMD? For those of the uninitiated, TMD is temporomandibular joint disorder, singular. TMD is not a bunch of disorders. I've spoken on that before, but as long as I brought it up, it is a disorder of the inflammation within the temporomandibular joint. It is a disparate series of symptoms which include bad headaches, but has multiple other symptoms. That alone is one way to distinguish whether or not your bad headaches may actually be TMD and not migraines, as they say in Tennessee, migraines. The other symptoms of TMD include, besides bad headaches, earaches, jaw pain, neck pain, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, ringing in the ears, tinnitus, subjective hearing loss, which is feeling of fullness in the ears, dizziness, vertigo, and multiple various types of jaw locking. We find that a huge number of people who have been diagnosed with or told they have migraine headaches don't have migraine headaches, they have TMD headaches. And often they share some of those other symptoms, which is a very good way to distinguish, not the only way, but a very good way to distinguish whether or not your headaches are migraines. Now, let me make this point about migraine headaches. I am also a physician and have academic degrees in cell biology and anatomy, and quite a bit of experience in research, my own research, which was focused on facial growth and development as a maxillofacial surgeon with the National Institute of Health, National Institute of Dental Research, and craniofacial research. And along those lines, I know how to read science. And there are a lot of scientific articles written on migraine headaches. Let me make a comment about migraines. Migraine is nothing more than a Latin word or term meaning pain in one half of an area. Migraine. Frankly, it's a catch-all phrase because due to television and the internet, everyone thinks that if they have a bad headache that they can't explain, it's got to be a migraine. But getting back to the definition of migraine, which I basically said, the science that is written, and it's good science, good scientists try to study these very difficult to understand headaches. And the first paragraph of most of the good studies admit they don't know what causes migraine headaches. There are a lot of theories, and we don't need to go into theories because they are just theories. And maybe one or more of them may be true, but right now, good scientists, they cannot pin down for sure what causes migraine headaches. And that's the science behind it. Now, what my physician colleagues do, whether they're PCPs or family practitioners or neurologists, those are the three categories who would most likely be trying to treat bad headaches in the medical field. The only thing they have to offer are medications. Before they give medications, they usually do a very extensive and expensive workup. If you come into a family practitioner or a PCP with a history of bad headaches, one of the first things you're going to get ordered is an MRI looking for brain tumors or any other problems that may be visualized on an MRI in the brain. And the chances of that showing up anything that's positive are frankly slim to none. But they get that to make sure that those are not missed. And I couldn't necessarily argue with that, but the odds of finding a brain tumor or a stroke when someone enters with a history of bad headaches is significantly less than 1% of the MRIs ordered. And those patients have been, one way or another, given the diagnosis of migraine headaches. And again, the science has no idea what causes migraines. Now, what we do know, what I can say from my experience with 50 years treating temporomandibular joint disease, both surgically and now for the past 14 years non-surgically, is that a huge number, I cannot quote the number itself, I don't want to try to quote the percentage itself of patients who have been diagnosed as migraines who have TMD, but we see a huge number of patients who have been diagnosed with migraine headaches that actually have temporomandibular joint disorder, and their pain is coming from pain generated by inflammation within the temporomandibular joint, causing the muscles of mastication, which include muscles all over the face and include muscles that are inserted in the bones all over the face, from under the chin to the top of the head. And when those muscles get a signal to tighten up, don't move the jaw joint, we're going to help you out. Brain says, we see you're inflamed. I'm going to help you out. Tighten the muscles that move the jaw joint. And wherever those muscles are attached to the facial skeleton is where it generates pain, stimulates the pain receptors. When that goes on beyond just muscles of mastication, the brain says, I told you don't move the jaw, now I want you to move the whole head tight, and patients will complain of not only neck pain, but headache in the back of their head where the trapezius is attached, because maybe too big a word for everybody, sternocleidomastoid and trapezius that basically move the head posterior tighten up and they pull on the bone and pull on the nociceptors, the sensors that are attached to the bone, periosteum, and create pain, which the patients interpret as headaches. And the headache can be misinterpreted as sinus problem because it hurts through here, where the muscles of one of the major muscles, the masseter muscle, is attached to the zygoma, create pain in through here. Up here, hurts there every morning, hurts here, mylohyoid bone. That is the pathophysiology of TMD, which has nothing to do with the science that is studied as migraines. So I am not trying to say there is no such thing as a migraine headache. If it originates, there is no science proving where and how. But it is a catch-all phrase that my medical colleagues use. They are my colleagues. I am also a medical doctor. who use medications, various medications, mostly medications that suppress the nervous system in one way or another, trying to alleviate this pain. Of course, all kind of other medications, neuroleptics, narcotics, muscle relaxants, but the categories that are used most often are something having to do with depressing the nervous system, hope being that it will alleviate the headaches. Basically, it's taking a medication, thrown against the wall to see whether it sticks or not. And that's the so-called science behind migraine headaches. But there's good science regarding TMD. There are multiple excellent studies which depict how the autonomic nervous system of any joint, including the temporomandibular joint, this would include the knee, the hip, the elbow, any joint, all joints work the same way. And there's really good science which proves that the autonomic nervous system tries to help a damaged joint by sending signals to the muscles that move that joint to hold tight, to contract, to get stiff, and pull on the bone and try not to move that joint. And that's what applies to this temporomandibular joint also. The dental schools teach that this joint is different. It's unique. Every dental school teaches this. I have never talked to a dentist who denies or disagrees that that is what they were taught in dental school. They were taught in dental school that this joint is different, unique, complicated. It has a funky name. It has a funny name, guglio-arthrodial joint. It's a categorization of a joint, guglio-arthrodial joint. It has a different name, and because it has a different complicated name, it must be a complicated joint. That's their theory. That's their justification. Well, it's not. This joint operates just like the knee and the elbow and the hip as it regards to how the joint operates or doesn't operate under the influence of inflammation within the joint. When the knee gets inflamed, it sends a signal to the brain stem. This is in the autonomic nervous system, the quote automatic nervous system that controls your breathing and your heart rate and all other kind of functions, gastrointestinal. It's hooked into the other systems of the body, the endocrine system especially. But when a joint becomes inflamed, it sends a signal to the brain. The brain stem says, I'm inflamed. Brain stem says, I'm going to help you out, tighten the muscles that move that joint. And that applies to every joint, including the temporomandibular joint. That is the pathophysiology that is literally unacknowledged at this time by the dental profession, by the dental industry. No one has ever tried to correct me on this because they know it's true, but they continue to hold that TMD is a multiple cause disease from multiple causes and try to treat symptoms only with all kinds of things, drugs, Botox, physical therapy, psychiatric treatment, psychologic treatment, physical therapy with dry needling, all intended to treat a specific symptom, but you can imagine that if you can actually treat the cause and make the chronic inflammation within the temporomandibular joint diminish, then the symptoms won't appear and the symptoms will go away. And that is exactly how a device that unloads the jaw joint makes the symptoms go away. It makes the inflammation go away. If you have a bad knee and you go to the orthopedic surgeon with a chronically damaged and painful knee, he will do a workup and an MRI or probably a CT scan, and he will say, you have a very damaged knee. You're going to need a total knee replacement. And if you said, I don't want a total knee replacement, what else you got? He would put you on a set of crutches. Rightfully so, correctly and tell you that if you stay on the crutches, your pain will go away. And the reason the pain will go away is that the chronic inflammation in the knee would go away once it is unloaded. Once the knee is unloaded with a set of crutches, the chronic inflammation will dissipate and the pain will dissipate. But if you get off the crutches, then the pain will come back. That's why surgeons are able to do surgery, because people don't want to spend their life on a set of crutches. Well, that same theory, it's not a theory, same fact, operates this device, which separates the back teeth. 90% of the loads on the temporomandibular joint are from the posterior teeth. If you separate the back teeth, you take 90% of the loads off of the jaw joint by separating the back teeth with a device that is easy to wear, easy to talk with, can be worn 24/7 without any problem. Separating the back teeth, taking the load off the temporomandibular joint, allowing the inflammation within the temporomandibular joint to dissipate and go away, at which point all of the symptoms, including migraine headaches, will go away, as long as you use this device according to the protocol. What is the protocol? You have to start out strong, 24/7. That's 24 hours a day, 7 days a week for the first 2 months. Then nighttime, sleep time, assuming most people sleep at night, nighttime, sleep time, the rest of your life. And that protocol has been proven, been worked out to show that that is enough unloading this joint to keep the inflammation down to the point that it doesn't create symptoms, or if it has created symptoms, that the symptoms go away. So both your current symptoms will diminish, and it keeps you from getting any additional symptoms in the future. And TMD is a progressive disease. It progresses over time due to 3 causes that cause damage to the joint. There are 3 causes that damage the joint. The first being chronic clenching and grinding, which we call bruxism. Number 2 is acute trauma, which most often nowadays is motor vehicle accidents, but can also, in Tennessee, caused by horse misadventures, falling off a horse, which is very common in Tennessee. Childhood injuries over the handlebars of a bicycle, acute trauma to the jaws, the face, the head, especially motor vehicle accidents, and whiplash. And then the third is functional malocclusion. We're not talking about not having perfectly straight teeth. We're talking about occlusions that are so bad that it overloads the joint. We call those functional malocclusions, which can be seen in some patients visually: big jaws, set back jaws, open bites, basically funny looking faces. But it doesn't have to be severe. It can be a very small difference between the 2 bites that everyone has. And if you have a significant difference between bite 1 and bite 2, we call it a functional malocclusion, and those malocclusions can overload a joint to the point that the joint begins to break down. Once broken down, it creates chronic inflammation. Chronic inflammation causes the symptoms, the most common of which is bad headaches, which we call TMD headaches. It's one of the major symptoms, the major symptom of all the people we see in our practices and the doctors throughout the United States who use this device and protocol. The most common symptom is bad headaches that the patients present, calling migraine headaches. So the original question is, are my headaches migraine headaches or TMD? There's one other feature that needs to be discussed. Historically, this is historically now, over the past 50 years since I was trained in both dental school and medical school, the differentiation, the primary differentiation between any other kind of headache, something that is called a cluster headache, very common headaches are called tension headaches, which they know there's something having to do with anxiety and stress that has to do with this headache. and overlook the fact that anxiety and stress can cause bruxism, which is the only thing we know about bruxism. The only thing we can say for sure about bruxism, it's related to stress and anxiety. How that works in the brain, how stress and anxiety converts into clenching and grinding the teeth, we have theories, but we can't say for sure. But we don't know actually the mechanism that causes bruxism, although we know for sure it is related to stress and anxiety. But that's the medical doctors have a second category, a third category of headaches called tension headaches, anxiety headaches. And so you can see where the confusion can come up. But getting back to migraine headaches, the migraines have been distinguished from any other kind of headache over the past 50 or 60 years because of what the doctors say, that migraines distinguish themselves because of visual disturbances, visual aura of different types. It can be spots, it can be visual limitations, it can be blurriness, but visual disturbances. Well, it has been seen, it has been noted several times in this practice that visual disturbances will diminish when the temporomandibular joint is treated with a device that makes the inflammation go away. And the reason that that occurs, and again, I am qualified, trained as an anatomist and cell biologist, so I know my anatomy. The muscles that move the eye are closely related in the brainstem, in the areas we call nuclei. The nuclei that drive, that's the origin of the nerves that drive the facial muscles, the trigeminal muscles in particular, and the nuclei, which are in the brainstem, that drive the muscles that move the eye. There are three separate nuclei in the brainstem that control the very small, they have to be very small motions of the eye and coordinated between two eyes. Those nuclei are extremely close to the nuclei that drive the muscles of mastication. So although I will not say it is proven, it is frankly, is definitely possible and very likely that when the brain is given the signal that there is inflammation in this joint and it goes directly to the brainstem, which controls the muscles of mastication, there can be some bleed over or some confusion in those muscles because the nuclei are so close together, which sends erroneous signals not only to the muscles of mastication, but to the eye. We have seen several, more than this many, patients whose history of aura or visual disturbances associated with their migraine headaches, misdiagnosed migraine headaches, also clear up when the inflammation in the temporomandibular joint goes away and their headaches go away, which would make a case, could make a very good case and a very good study, which we do not have the time currently or the resources to perform, would make a very good case and study that would prove that aura can actually occur in TMD headaches and is not the distinguishing factor between migraine headaches and other kind of headaches. We have seen that. We have seen that because we see so many patients. This practice over the past 10 years has treated successfully well over 5,000 TMD patients, most of which presented with a history of migraine headaches. I hope I've enlightened you on this topic, on the topic of are my headaches migraines or TMD? My wish is to enlighten you, to educate you, to make you think about this problem in a different viewpoint. We do know absolutely that a huge number of patients who have been diagnosed with migraine headaches have been generated by TMD, temporomandibular joint disorder, The definition of that is inflammation within the temporomandibular joints, which drive all the symptoms, which I've described how that happens. With that as a finishing statement, I look forward to the next time you'll visit this podcast, the next episode, which is always done on a Tuesday morning. I enjoy sharing my knowledge with you. I hope that it is meaningful to you. I hope whether you are a practitioner, a dental practitioner, maybe a medical practitioner, or a patient, or especially a patient with some of these symptoms of TMD, especially migraine headaches, will take a viewpoint on this and investigate. If you'd like to learn more about what we do in our practice or in the part of the practice that has other doctors using this device, which is called TMJ Services, you can get all that information on www.urbanektmj.com. If you'd like to communicate with me, I am available at tony@tmjservices.net. Tony, Tony, at TMJ, Tango Mike Juliet, services plural.net. Until next time, I am Tony Urbanek, and this is TMD Demystified.